Indirect pulp capping. It is defined as a procedure wherein the deepest layer of the remaining affected carious dentin is covered with a layer of biocompatible material in order to prevent pulpal exposure and further trauma to the pulp. Here, the remaining affected carious dentin is present. It is not removed. After this, we have to apply the biocompatible material. These material produce remineralization. This material prevent the pulpal exposure and further trauma to the pulp. So we have to save the pulp by this method. Here the important point is remaining affected carious dentin is present. The important objectives are preserve the vitality of the pulp, removing the carious infected dentin completely, placement of a biocompatible material for a remineralization, bacteria are eliminated from the lesion. The ultimate objective is to preserve the vitality of the pulp by completely removing the carious infected dentin. So here important point is the carious infected dentin is completely removed from the tooth, followed by placement of a material that would enable the affected dentin to remineralize by the stimulating the underlying odontoblast to form tertiary dentin. Amount of tertiary dentin formed per day is 1.5 microns. It takes up to 30 to 48 days for the tertiary dentin form completely. Studies have shown that physiological remineralization can occur only if the affected dentin layer contains sound collagen fibers and living odontoblastic process. The sound collagen fibers function as a base to which apatite crystals attach. The living odontoblastic process supply calcium phosphate from the vital pulp for physiological remineralization. Here, the indirect pulp therapy, the outer layers of carious dentin, that is infected dentin, are removed. So, obviously the bacteria are eliminated from the lesion. So, when the lesion is sealed, the substrate on which the bacteria is act to produce acid is also removed. With the arrest of the carious process, the reparative mechanism is able to lay down additional dentin and avoid pulpal exposure. So, exposure of the pulp occurs when the carious process advances faster than the reparative mechanism of the pulp. So, here important object is preserve the vitality of the pulp and remove the carious infected dentin completely, and placement of the biocompatible material for remineralization. So these are the important points here. So we have to understand indirect pulp capping, we remove the infected dentin only, not the affected carious dentin. Advantages of indirect pulp capping. Patient comfort is immediate. Disinfection of the residual affected dentin is more readily accomplished. It preserves the pulp vitality. Rampant dental decay halted when all carious teeth are treated. It eliminates the need for more difficult pulp therapy by arresting the carious process and allowing the pulp reparative process to occur. So these are the important points for the pulp capping therapy. Indirect pulp capping therapy. That is, disinfection of the residual affected dentin is more readily accomplished, and it saves the pulp vitality, and patient comfort is immediate. Rampant dental decay is halted when all carious teeth are treated. Next, moving on to diagnosis. First, we have to take the history of the patient. Patient complains of tolerable dull pain with mild discomfort associated with eating. Mild to moderate pain is experienced on thermal stimulation. There is no history of spontaneous or excruciating pain. So, patient complains of tolerable and dull pain with mild discomfort associated with eating. No spontaneous pain. Next, moving on to clinical examination. On examination, large carious lesion is found without any frank pulpal exposure. So, large carious lesion is present but no exposure of pulpal. There is a positive response to EPT, electrical pulp sensitivity test, and thermal stimulation and test cavity. The tooth respond normally to percussion. There is no tender on percussion. Next, moving on to radiographic examination. Radiograph shows a large carious lesion with a possible pulp exposure. The extent of caries penetration depth is up to 3/4 of the entire thickness of the dentine or more. Lamina dura is normal. Mainly the radiograph is taken for the rule out any periradicular pathosis is present or not. So radiographic examination, we saw the large caries lesion with a possible pulp exposure, but no change in the lamina dura and no change in the periapical region. Clinical procedure. Indirect pulp capping can be performed as in single or two-step approach. Two-step approach is otherwise known as stepwise excavation. In single sitting, the restoration process done in single appointment. In stepwise excavation is a technique in which caries is removed in increments in 2 or more appointment over a period of few months instead of trying to remove the caries in a single sitting. In this technique is indicated for deep carious lesion with no symptom of irreversible pulpitis. In this technique, only a part of the soft dentine caries is removed at the first visit and the cavity is restored and reopened after a few weeks. So, deep caries lesion with no symptoms of irreversible pulpitis. These are the indicated tooth for the stepwise excavation. And in first sitting, we have to remove the soft dentine caries only. Then another few weeks, in second appointment, we have to restore the tooth and reopen and clean the tooth after giving restoration. Further excavation is then done before giving the final restoration in the second visit. The objective of this technique are as follows. Arrest caries lesion progression. So caries lesion progression is stop and allow the formation of the reparative dentine, and pulpal exposure is less. In clinical note, the two most important factors determining the success of the indirect pulp capping. One is remaining dentine thickness and another one is choice of an indirect pulp capping agent. In remaining dentine thickness, this is the amount of remaining dentine present between the floor of the cavity and the pulp space. RDT. Normal is 0.5 to 2 mm. It has a good prognosis. 0.5 to 0.25 mm is reduces the prognosis or poor prognosis. The rate of the reparative dentine deposition is per day is 1.4 micrometer per day. Its formation decreases after 48 days. Greater dentine formation is observed in primary teeth than the permanent teeth. These are the important points in remaining dentine thickness. How to measure remaining dentine thickness? Use prepometer. These are the instrument used for the remaining dentine thickness. Prepometer. Green, orange, red color is available. Green is adequate and orange is minimum. Red is too close to the pulp. These are the device used for RDT. And moving on to choice of an indirect pulp capping agent. Most commonly we use calcium hydroxide dressing for the deep caries lesion. Calcium hydroxide has a long track record as a time-tested indirect pulp capping material, basically due to its high alkalinity and its ability to produce a dentinal barrier or dentinal bridge. Indirect pulp capping. Presence of deep caries lesion without any pulpal exposure. First step, give anesthesia and rubber dam isolation. Then removal of caries. Infected dentine partially removed with a round burr in a slow speed handpiece. Peripheral carious dentine removed with a spoon excavator. If there is no pulpal exposure and no signs of irreversible pulpitis, then give the calcium hydroxide on the remaining infected dentine and overlaying base of IRM. Wait for 6 to 8 weeks exactly. If patient is asymptomatic, then give anesthesia and rubber dam isolation and remove the temporary filling material. Careful further excavation and clinically confirm the change in color and hardness of the affected dentine. Hard set calcium hydroxide is placed followed by an RMGIC, resin modified GIC base, and a bonded composite restoration or amalgam. This is the final restoration. First we have to give calcium hydroxide, then give the final